Hi, good evening, everybody. Once again, warm welcome to you all for this month in endoscopy. This is 34th consecutive session. This is today being presented by Dr. Manas Panigrahi from AIMS Bhubaneswar. And we are delighted to have two esteemed panelists for our session today. Professor P. Shravan Kumar sir, who is Professor and Head of the Department of Gandhi Medical College, Hyderabad. And he's joined by Dr. Vikas Singla, who is Senior Director and Head of the Department at Max Hospital, New Delhi. So over to you, Dr. Manas.
Thank you, Dr. Chalapati, and good evening, everyone. And again, once again, welcome Professor Dr. P. Shravan Kumar sir and Dr. Vikas Singla sir. So this 34th edition of our this month in endoscopy. The outline of our journal club will be, I'll be presenting one article on gastroparesis published in endoscopy and another article in transpancreatic sphincterotomy. We have already discussed this sort of article previously also, but this is an interesting one that is on quality in low volume setting, and another article in pneumobilia after CVD clearance, so published in GI endoscopy. So straight away going to the first article we'll discuss. This is published in the Endoscopy in 2024 this month, and this is title of the article is gastric peroral endoscopic myotomy versus botulinum toxin injection for the treatment of refractory gastroparesis, result of a double-blind randomized control study, and this is from the France group. And why this study is important? If you'll see gastroparesis, it is a symptoms, a non-specific clinical symptoms having absence of lesion on upper GI endoscopy, and the result of gastric emptying scintigraphy. Non-specific symptoms like vomiting, satiety, and um, uh, bloating. These non-specific symptoms are there, and when upper GI doesn't show any obstructive lesion and there is specific result in gastric emptying scintigraphy, then we call it is gastroparesis. We'll see prevalence is around 24% per lakh, and we will see etiology. Most of them are mostly diabetic, idiopathic, and post-operative. So out of 100, if we'll take 100, 90 to 95% will cover these three etiologies, will cover around 95%. And this symptomatology will be vomiting, which is again subclassified into graded in three grade, and satiety and bloating. And we know gastroparesis in our daily OPD basis, we used to treat by dietary modification, we used to advise dietary modification, and co-kinetics. At times, we used to give promacin and ondansetron, we used to give. We'll see pathophysiology of gastroparesis. Most important two interesting theory are there. That is impairment of enteral motricity, that the intestinal cells of their propulsion activity is decreased, and reduced pyloric myorelaxation. So pylorospasm will be there, and thereby this emptying will be delayed. So this studies is a prospective double-blind randomized control trial conducted in two center of France, and they have studied this during September 2016 to May 2019, and they have included patients who are more than 18 years old, having these symptoms for more than 1 year, and refractory to optimal medical treatment. That means they have taken dietary and prokinetic medication for more than 6 months. They have taken, and they are no sufficient results. They have got symptomatic relief. They have got, so that is refractory gastroparesis, and they have included severe, that is pre-inclusion, that is gastroparesis clinical symptoms index score is more than 2, then only they have included in this study, and they have confirmed by recent gastric emptying scintigraphy that should be done within 3 months and a normal upper GI endoscopy. There should not be any ulcer, pyloric ulcer, duodenal ulcer, any malignancy growth, so that there will be any obstruction there, and that upper GI also should be done within last 3 months. And they have excluded younger population less than 18 years, pregnant, breastfeeding women, and when there is anesthetic contraindication, because both the procedure have done under anesthesia, and use of curative dose of anticoagulation and double antiplatelet medication, because they have used endocard mode in this thing, and where suspension was contraindicated and inability to provide informed consent. So this group of population has been excluded. And with the aim to compare this G-POEM versus botulinum toxin injection for the treatment of refractory gastroparesis. That is the main aim of this study. And they have assessed this by primary outcome measures is clinical efficacy in the gastroparesis clinical symptoms severity symptom index score decreased by more than 1%. That is, previously a lot of literature says GCSI score, if it is decreased more than 0.6, then it is clinical efficacy. But in this study, they have taken more than 1. Score decrease is the clinical efficacy of G-POEM compared to botulinum toxin at 3 months, which is assessed by GCSI score. And secondary outcome is like previously, they have again taken 0.6 as a criteria also, and they have studied clinical efficacy by taking consideration of decrease in GCSI by 0.6. Clinical efficacy at 1 year, that is GCSI, decreased by more than 0.1. Quality of life they have seen by taking ASAP's 12 questionnaire and GIQLI score, that is GI symptoms quality life index score. Improvement in the main gastric emptying scintigraphy findings and the rate of adverse event they have taken as a secondary outcome. If you'll see the procedure, what they have done, that is classical G-POEM procedure, they have injected that blue saline into 5 centimeter just proximal to pylorus, that is posterior wall of pylorus, and they have injected saline. Then they have given a nick. Then they have, just like third space endoscopy poem, they have tunneling has been done till pyloric arch. Then retrogradely they have cut these muscles up to 2 centimeter from the pyloric arch proximally. Then they have clipped, endoclip has been given to the cut person. And botulinum toxin injection, they have injected 200 international unit of botulinum toxin into the 4 quadrant by 23 gauge needle in single setting. And both the procedure has been done under anesthesia. So this is the concert diagram. 40 patient included and randomized. G-POEM 20 patient, botulinum toxin arm 20 patient. However, when evaluation done at 3 months, 3 patient has been lost to follow-up at botulinum toxin arm. So they have evaluated per protocol analysis has been done at 3 months in 20 patient in G-POEM arm, 17 in botulinum toxin arm. And when they have seen the clinical efficacy as 1 year, again lost to follow up 2 patient in G-POEM arm, 3 patient in botulinum toxin arm. So they have intention to treat analysis. They have done 18 patient in G-POEM and 14 in botulinum toxin arm. However, they have analyzed for protocol wise also in 3 months and 12 months. So if you'll see the baseline characteristic of both the arm, there is no much difference. And etiology, if you'll see, most of the patient belongs to this idiopathic group. And otherwise, age, BMI, all those GCSI score, all these things are, there is no difference between the G-POEM arm and botulinum toxin arm. And gastric emptying scintigraphy, they have seen half emptying time, 2 hour and 4 hour residual solid activity. But there is no difference in both the arms. So this is again the baseline gastroparesis cardinal symptom index, and as we discussed in this vomiting subscale, there are 2 points: retching and vomiting has been given, and satiety subscale 4 characteristic, that is early satiety, not able to finish a normal meal, postprandial fullness, loss of appetite, and this bloating scale, they have bloating and stomach belly visibly larger. And they have seen total GCSI score, that is 3.6 in GPOM arm and 3.3 in the botulinum toxin arm, and there is no significant difference between both the arms. So this is the primary outcome. They have seen the efficacy at 3 months and 12 months, and here we can see clearly at 3-month clinical success rate, GPOM 65%, whereas botulinum toxin is only 40%. That is significant difference between GPOM and botulinum toxin. That is 3-month clinical success rate. That is again GCSI score more than 1 decrease. And again 3-month clinical success rate, when they are taking GCSI score decreased by 0.6, again GPOM arm is clinically significant difference between the GPOM and botulinum toxin arm and GPOM score over botulinum toxin. But if you'll see at the GCSA mean change, 12-month clinical success rate and 12-month mean GCSA mean change is 12 months, there is no difference. Of course, there is though there is no significant difference, but we can see maximum clinical improvement is much more in GPOM arm, that is 60% versus 40% than botulinum toxin now. So clinically, it is more beneficial in GPOM arm, though it has not achieved clinical the statistical significance. And this is again the 3-month and 12-month GCSI score, and there is no difference between the GPOM and botulinum toxin arm. So they have discussed efficacy rate of GPOM at 1 year was 60% with no severe adverse event and low overall adverse event rate. And at 1 year, the efficacy rate was 60% for GPOM versus 40% in the botulinum toxin group, though it is not achieving statistical significance. And statistically significant difference at 3 months, but not at 1 year, but clinical difference of 20% they are achieving in GPOM arm. So this study confirms the interest in treatment targeting the pylorus either mechanically or chemically in treatment of refractory gastroparesis. So if you'll see the strength and limitation of the study, this is the first double-blind RCT done to show the difference between GPOM versus botulinum toxin, and two-center has been multi-center. It is 2 centers have been participated. Though both the center are expert, they have expertise in this third space endoscopy. So difficult to generalize in those non-expert center or whoever those who are not very much experienced in this third space endoscopy. And regarding strength is again they have taken gastric emptying scintigraphy into the validated. They have taken the criteria of American neurogastrointestinal motility criteria, and they have validated in this study also. But limitation, no SAM group is there because in their ethics, they have not allowed any SAM group, and low power because of less sample size. And in botulinum toxin arm, around 6% lost to follow up at 1 year. Maybe because of not significant improvement in botulinum toxin arm, and they have seen those patients are coming from other countries and they have lost to follow. So take home points from this study is gastroparesis is a significant problem with high prevalence rate, having poor quality of life of patient, and we can target by this both the method chemical and by cutting mechanical also. And GPOM is quite promising, safe method with clinical efficacy of 60% and 1 year, and it is approved by ESGE also. GPOM can be done in refractory gastroparesis. To our panel, esteemed panels.
Thank you, Manas. I think gastroparesis is a very common issue, and patients are troubled a lot. So when we are offering a invasive treatment like GPOM, we expect a durable treatment. So first, the primary endpoint is efficacy at 3 months only. Like in when we do POEM, we take a 1 year efficacy at 1 or 2 year as a primary endpoint. So I think 3 months is too early time for a chronic illness when we are offering a invasive treatment like GPOM, which can be associated with the complication. The endpoint should have been, I think, at least 1 year. And second, the previous studies has taken primary endpoint as a 50% reduction in GCSI score. I think if you're taking reduction of only 1 point when the baseline is 3.6 and you are reducing it to 2.5, 2.6, is that a clinically meaningful score, meaningful endpoint? So that's my concern. So I think the ideal endpoint should have been the at least 50% reduction in GCSI score at 1 year. And second, they didn't calculate sample size. So with a 40 study of 40 patients only, I don't think until unless there is a difference of 70-80% in two groups, you are going to reach any meaningful, significant conclusion. Here we can see difference in 20%. That's expected actually. The previous study has shown that GPOM is effective only in the 50 or 60% of patients. And in the Botox is effective in 30 to 40% of patients. So we know that the difference should be around 20%. So this study is definitely underpowered. They didn't calculate sample size. That's why we couldn't find the statistically significant difference in this study. And second, regarding efficacy, when we are offering a invasive procedure, when you tell patient efficacy will be around 50-60%, I think that is difficult to, this method will be difficult to adopt in our practice actually. So even with the poem, sometimes we struggle to convince our patients. When we tell them efficacy 90%, still they are worried about 10%, 10 failure chance. So the invasive procedure, which has an efficacy of 50 to 60%, will be difficult to adopt. And I think we have to find out predictor of response. So that we can, so before this treatment, we have to find a predictor which can tell us which patient are going to respond better. So at least the efficacy should be 90% in the selected patient. So I think in the previous study, more than 20% retention rate, if the patient has a retention of more than 20% at 4 hours, and if the GCSI more than 2.6, these were the predictor of success of GPOM. In the study, they have selected patient who had a retention, I think around 40%,
Yes.
and the GCSI was 3.6. Still, the efficacy was only 50 to 60%. So I have real concerns before adopting this procedure in my clinical practice. So I think what we are lacking right now is the entoduodenal manometry. Like, so we should define which are the patients who are likely to benefit. So enteral, so there are two components. One is the enteral motility, which is not going to improve. So I think which will further go down. Once you're cutting the enteral muscle, the enteral motility will go down further. And so but we are targeting only the pyloric sphincter. So whether with the endoflip or with the entoduodenal manometry, we can find out the patient who are having really pyloric obstruction. These are the patients who are likely to benefit. Or what is other option? We can use Botox as an initial trial method because both are targeting the pyloric sphincter. So initially, one may inject Botox. If these patients improve with the Botox, these are the patients which may improve with the further pyloric guided therapy. And previously, I think Kasab group had tried the stenting also. They place a stent across the pylorus, and patients who improve with the pyloric stent were more likely to improve after the pylorus guided therapy. So definitely this procedure has a potential, but efficacy still remains low, 50 to 60%. So I think we have to select our patient very carefully. So when we are
Yes.
doing G-point, 2 out of 1 will respond. And other thing, the effect is not durable. So the GCSS score again increase at 1 year. So we need more durable procedure. That's my concern.
Yes. Thank you.
Shravan, sir.
Am I audible?
Yes, sir.
Actually, this procedure, what have been, is emerging procedure. But the thing is, the number of the patients which have been given in this article, no. So that is a small sample size. Maybe the requirement of a big number of samples so that we can have a very good results. So that we can say that really GPOM is working very well. Here is the Botox is also there were significant. The results were very good on par with GPOM. Of course, the when a comparability is it is lesser than the GPOM. And overall, I think patient selection has the diversity of the patient selection. Etiology also different etiologies they have been mixed up. Here the idiopathic group is more, I think, no? Chelopathy?
Idiopathic.
Idiopathic group is more. I think the diabetic patients are doing very well if glycemic control is well compared to idiopathic group. And here they are not mentioned about the glycemic control of the diabetes also before they are taken up the GPOM levels. And overall, the response rate is everything is 1 year is insufficient, as Vikas Singla has already told that it requires for more years to say that whether they are significantly better or not. Maybe the 3 months duration is very, very early to say. The efficacy rate to say that 3 months is very less amount. But overall, the 1 year is also insufficient to say that since it is a invasive procedure, maybe it requires more number of patients and longer duration of observations are required. As Vikas Singh already told that anteroduodenal motility is a vital part before we taking up for the GPOM. Anteroduodenal motility is because that is the antegrade motility is more significantly important. How much of motility is taking place before we do the GPOM? So these are the important things which you can draw the conclusions about this study.
Thank you. Thank you, sir.
Can I make a point?
Yes, sir.
Yeah.
Regarding loss of follow-up, so they could have easily called patient by telephonically, and they could have easily gathered GCSI score. So their main endpoint was revolving around the GCSI score. So they could have easily sent a mail, or there are only 40 patients. And once you do a procedure on a patient like GPOM or Botox, you have a good relationship with the patient. They will easily take your calls. So like we are collecting our poem data. So we are calling our patient every 3 months. And the response rate is around 95%. So I don't know why there was a dropout of 7 patients in the Botox group and I think 3 patients in the GPOM group. When you could have easily sent by mail or the telephone, you could have collected this data. So that is difficult to explain actually.
And moreover, yeah. And moreover, is the Botox is not a very invasive procedure, so the patient can be easily, we can get the information and we can call them back also, because it is not much invasive procedure. They will happily, they might have come back to the center wherever this is being done. So I think whatever is said, the dropout rate is also, the follow-up is also significantly high in the study. So the concluding the study is a little bit ambiguity is also there, because the less number of sample and the duration is also not significantly high number of months is also not been observed.
Any comment, Chalapati and Nitin?
Yes, regarding this GCI score, if you try to see this question, and I think there will be a bias for any patient who underwent procedure, and the difference of they, as Dr. Vikas has said, they have not targeted more than 50% improvement, but they just have taken some random decrease in, and they also for that GC ISA, if you consider a statistical analysis, it's not a continuous variable. It's something like ECARD score only. And when you want to analyze with the statistical methods, it's very difficult for smaller size. You need to use non-parametric test, and then the whole statistical analysis will go haywire. That's 2 points from my side.
Lot of subjectivity in this call.
Yes.
Dr. Rao, Chalapati?
Yeah, fine. I think nothing from my side. We'll move on to the next lecture. Next topic.
Thank you. So the next is published in Gastrointestinal Endoscopy, the impact of transpancreatic pre-cut sphincterotomy on the quality of ERCP in low volume setting. So why this study important? Quality of care, we know, increases the likelihood of desired health outcome, and that is the not the quantity. Now people are more into, that is public, corporate, everywhere they want quality care. ERCP is technically demanding, we know that, high risk procedure, and ASG has proposed 15 quality indicators. But the priority indicators like appropriate indication, cannulation rate, stone extraction success rate, 10 insertion rate, etc. are there, and of course post-ERCP pancreatitis. Out of these, cannulation rate and post-ERCP pancreatitis rate are highly correlated with cannulation technique. So these two rate are the most important indicator. So average primary cannulation rate of standard cannulation technique is around 77 to 83%. And what are the factors affecting this cannulation rate? There is papilla morphology. We know there are 4 types of papilla. Periampullary diverticulum. Again, 3 class of diverticulum are there. Any surgical altered anatomy and operator experience are there. These are the most important factors. And we know when we failed normal cannulation technique, advanced cannulation technique, they are like needle life sphincterotomy, needle life fistulotomy, double guided technique, this transpancreatic sphincterotomy, and rendezvous technique. And TPS initially described by Job in 1995 and was reported to have 97% success rate for cannulation, and rate of PEP, that is post-ERCP pancreatitis, was comparable to the standard cannulation. And ESG kept TPS as last resort, though needle knife is technically more demanding than TPS. So why this needle knife is more demanding? Because our standard sphincterotome, we are again TPS and standard cannulation is similar sort of. Here only we have entered into PD, and at 11 o'clock direction under the guide wire will be there, and we are cutting at 11 o'clock direction. However, needle knife is completely different. We are going with a needle and cutting. That is more, learning curve is more technically challenging, and it needs experience. So aim of this study is to show the impact of this transpancreatic sphincterotomy technique on the quality of ERCP at low volume center. And we know low volume center and high volume center are defined when there is ERCP is done less than 200 per annum. It is called low volume center. And in a center where ERCP will be more than 200, it is called high volume center. And if you see experienced and non-experienced expert are those who are doing more than one sphincterotomy per week in knife papilla, then it is called expert. And if they are not doing less than one, it is called non-expert. And this study is a retrospective study done in a single center in Taiwan. And they have done from April 2013 to April 2019. Basically, in this, they have compared, in this center, they have started this TPS technique, pancreatic sphincterotomy technique in 2016. So what they have done, they have historical control they have taken from 16 before, that is 3 years before and 3 years after starting this TPS technique. So 3 years before, when they was not doing TPS, that are the historical data they have taken, and they have compared after they have started this TPS technique. And they have included more than 18 years. ERCP cases intended for biliary intervention included only with a knife measure papilla. And they have excluded when there is unable to assess papilla and those with surgically altered anatomy. If you will see the patient flow chart, out of 1043, around 30 are excluded, where 20 are unable to access papilla, and 10 are surgical altered anatomy. So ERCP around 1013, out of again few other interventions they have done, they have excluded. And ERCP cases having biliary intervention, 963 cases they have taken. And out of the 963 biliary intervention, prior manipulated papilla is 262. So they have analyzed 701 patient of ERCP. If you see this baseline characteristic of this TPS before TPS and after TPS, there is no much difference between the before TPS and after TPS group. However, you can see here this mm, male this biliary stones are mostly indication are biliary stone, and ampulla veter, if you'll see type 1 papilla is majority case, and diverticulum is type 3 type is diverticulum is majority in this case. But there is no significant difference between the before TPS group and after TPS group among the baseline characteristics. So this is the outcome of ERCP between 3 years before and 3 years after TPS. They have outcome assessment they have done, and here there is significant difference between the successful cannulation. If you'll see the before TPS successful cannulation rate is 87%. However, after applying this TPS technique, cannulation rate has been increased to 92%. And this post ERCP pancreatitis, there is no difference, and cholangitis, again there is no difference between these two groups. And this diagram shows, you'll see the diagram number A. Here they have seen all endoscopists before applying this TPS technique and after TPS technique. After applying this TPS technique, cannulation rate, biliary cannulation rate has been increased. And this graph B is showing in expert endoscopist. Expert endoscopist, there is not much difference, but again the cannulation rate is increased after applying this transpancreatic pre-cut sphincterotomies. And in non-endoscopist, non-expert group, endoscopy group, after applying this transpancreatic pre-cut sphincterotomy, there is significant jump in the cannulation rate. So this is performance and adverse event of TPS in this TPS compared to the standard. And here again we can see that this cannulation rate is 76% in the standard, whereas after applying TPS it is 94% around. And there is no much difference. There is no difference, statistical difference between post ERCP pancreatitis. Rather, after applying TPS, this post ERCP pancreatitis in this group is decreased. So there is no difference. And if you will see the impact of introducing TPS technique to expert and non-expert endoscopists, there is significant difference between non-expert endoscopic group. That is 85%. Cannulation jump to 93%. However, in expert, it is slight increase, but there is no statistical significance in the expert group. So this transpancreatic pre-cut sphincterotomy as a primary advanced cannulation technique in low volume ERCP center with lower case load can significantly enhance the quality of ERCP. Previously, there is a meta-analysis 2019 which shows success rate of 91% in treating difficult biliary cannulation with 7% post-ERCP pancreatitis in high volume center. Those are the study published in, that is meta-analysis of 14 studies. They have seen only in high volume center and expert endoscopist. However, this study shows in low volume center, and they have non-expert endoscopist also. And ESG also recommend a double guidewire technique once guidewire is in PD. However, meta-analysis in 2022 have shown clearly that this TPS technique overscored the double guidewire technique in rate of cannulation as well as in adverse event also. So we'll see strength of the study. This is the first study which has evaluated the quality of ERCP in bile duct cannulation in low volume center. And both expert and non-expert endoscopist has been taken into account, but limitations are, it is a retrospective study. As such, design of the study, there may be bias, recall, and all those bias will be there, though they have claimed that all photographs, all timing they have taken, but there will be definitely some bias will be there. Confounding factor will be by repeated practice, we can increase the cannulation rate. We know that. So that is an inherent bias in this study. And they have not taken, as per protocol, they have not taken any prophylaxis for post-ERCP pancreatitis like indomethacin, rectal endomethacin or rectal NSAID. They have not given, and no IV fluid during ERCP, RL. So that is, they have not taken. But they have recommended this, since they in low volume setting it is helpful, they have recommended when there is difficult biliary cannulation, that is after 5 attempts and 5 minutes, and unintentional pancreatic guidewire insertion is there, do a pancreatic sphincterotomy, then uh, go for double guidewire technique or transpancreatic sphincterotomy. Any technique we can go, but they have clearly mentioned that transpancreatic sphincterotomy is uh, clearly overscore over double guidewire technique. If there is failed to assess or something, then go for needle line, because this needle line precord sphincterotomy required a little bit of more experience, learning curve, and technically challenging. So this algorithm has been given by this study group, and over to you, sir, for this.
Thank you, Manas. Again, I think it's a very good article. So difficult ERCP is always a challenging situation. We are always worried about the success rate and the complication rate. And pre-cut has been standard of care. And the issue with pre-cut is it's difficult to master, no doubt. And second, we don't know about the depth. Till what depth we have to cut. It's a uncontrolled depth. So if you compare between the pre-cut and the TPS, in the TPS, we are going from below upward. So we know our lower limitation. So there is hardly any risk of perforation. And on the other hand, pre-cut is coming from above downward. So we don't know that till which extent, till depth we can go. So I think in terms of avoiding complication of perforation, in the beginner, in case of beginners, TPS may have lesser risk of perforation. And but I think we have to define method of TPS. We have to standardize this method. So till what length we have to cut the papilla, whether it should be 50%. So what should be the end point of transpancreatic septotomy? So whether we should cut the whole papilla, or it should be 30%, or we should see the flow of bile. So I think it's a good technique which can be adopted in practice, but we need more data. And I think in the last 1 decade, there have been a lot of publication about the transpancreatic septotomy. And I think more and more centers are now adopting this technique of transpancreatic septotomy. So I'm also using this technique for the last 15 years. So one aspect is that 4 type of papilla. So this technique can be used in any type of papilla, whether it's a small stenotic papilla also, or you can give a small nick. So you're always worried about the perforation in a small stenotic papilla when you are doing the pre-cut with the pre-cut technique. So this technique can be adopted in patient with the small papilla also. And other thing is that wire should go inside the PD. For this technique, one thing is that the wire should go inside the PD. So that's a limitation of the technique. But I think invariably, if the wire is not going into the CBD, 99% time the wire will go into the pancreatic duct. So this is a nearly unheard of, that wire is not going in either of duct. So if the wire is not going into the CBD, it invariably goes into PD. So that's why I don't think that's a challenging situation. So when the wire doesn't go in PD, then you have to resort to other methods like rendezvous or pre-cut technique. I think this is a good technique, but we need more data. So we need head-to-head comparison between the pre-cut and the transpancreatic septotomy. So we need a randomized control trial between these 2 techniques to define what is the risk and benefit. But yes, this technique, I personally favor this technique, especially when there is large papilla, you can easily cut that. So I think it's a good article, good technique.
Sir.
Yeah, this has been the practice which we adopt, when we are getting a training at the adoption of the practice. So wherever we get the practice of doing pre-cut, we have been doing a lot of pre-cuts only, maximum. But here, what Vikas Singla told that when the guide wire doesn't go to CBD, it goes invariable to PD. I think this we found that a lot of times when the guide wire doesn't go to CBD, even it doesn't go to even PD also. So the problem arises that when we're going to do the TPS, when guide wire doesn't go to PD, then that is a issue most of the times which we are going to do this kind of procedure. So this is all the individualized practice of doing ERCPs. Maybe the learning techniques which they do it at a proper center. If they are good at doing that procedure of pre-cut needle type of sphincterotomy pre-cut also, we have been actually sometimes the person those who are doing it, once they are getting in a more of their practice of doing it by their experience, I think they do it very well. Here, what Vikas Singla told that the same way, as the up to what level we have to cut it when the guide wire goes into PD, when we going to cut the sphincter at 11 o'clock position, how long, at what extent we have to cut the sphincter, that is the issue. So at the learning point, whether successful rate, whether we are going to become more successful or not, that is a question mark. Maybe we have to try more about this technique. I have not tried so far this technique, and have been adapted. So doing of all three cuts needle type sphincterotomy only. This is a good article. It's a kind of thinking where we can try this kind of technique also.
Actually, we are using this technique, and we found a very high success rate with this technique. We cut around 50% of papilla. So you have to relax the sphincterotome. When the sphincterotome is in the pancreatic duct, you have to don't make it tense. So should be partially tense, and then cut at 11 o'clock. We cut around 50%, and invariably you are able to pass a wire into the bile duct. But we also place a stent. Once we complete procedure, we always place a stent in the pancreatic duct before attempting the bile duct cannulation to prevent the post-ERP pancreatitis.
So
But
before,
my question is that when guide wire goes to PD and when we cut the at 11 o'clock position at TPS, and what is the rate of pancreatitis? How it is lesser than the routine time? That is what I am surprising.
So I think the rate of once you are going inside the PD, the rate of post ERC pancreatitis will be definitely high in these patients. So what we have to do, we have compare between we cannot compare it to the standard cannulation. We have to compare between the transpancreatic septotomy and the pre-cut technique. We have to compare these two groups. Definitely the risk is going to be higher than the standard cannulation.
Yeah, that's what. That's what.
Dr.
What do you say,
Rao?
Chalpati? What do you say?
Nitin?
So
Yeah, I mean, that's true, sir. But I feel like one of the important take-home point from this study is like in low volume center, when there is, especially for the non-experts and beginners, and there is a struggle to maintain the skill, and they want to master the or increase the cannulation rates, especially by using some form of pre-cut. So freehand technique, obviously, it has some of its inherent problems. But when guide wire is already inside the PD, that acts as a guide. You just bow it to the 11 o'clock position and do a transpancreatic sphincterotomy. Your pancreatitis rates are similar, your bleeding and other adverse events are similar, but success rate is even better. So it means like probably rather than struggling to learn a freehand sphincterotomy by a standard using a standard needle knife, and your wire is already inside the pancreatic duct, even beginners or non-experts can increase their cannulation rate if they start resorting to this technique rather than other techniques like double guide wire technique or over the stent cannulation or a freehand needle knife. So probably that is the important take home point from this retrospective study.
It is self-learned. This technique is self-learned.
Right. I think there is a question in the chat box before going to that. Dr. Subhash Majumdar has a question. In the algorithm proposed, how do we do a TPS after placing a pancreatic stent? So in the algorithm that Dr. Manas proposed, that you have shown, how do we do a TPS after placing a transpancreatic stent? So can you clarify on this? Yeah.
Basically, when there is you are putting a guide wire inside PD, then do a TPS, then put a stent. I think that is the most important. This is wrongly. I think this is right now, Singla sir, Vikas sir.
You are very right. So first, I think there should be a significant cut actually. So sometime if you don't cut and place a stent, then there is no space to pass a cannula above the
Cannula,
stent.
yes. Yes.
So if you're able to identify the bile duct opening, then over the wire you place a plastic stent, 3 or 5 French. Then over the stent you cannulate. Because once you have cannulated the CBD and place a stent in CBD, then it will be difficult to cannulate the
Cut.
pancreatic duct. And that will cause more trauma and high risk of pancreatitis. So always make a cut, place a stent, then try CBD cannulation.
Thank you,
And
Dr. Subhas.
I just want to make a comment. I think in the last 5 or 6 years, the number of publication on this technique are increasing actually,
Yeah.
Yes, sir.
and
True, true,
much
true.
easier than the pre-cut. I think in future I can foresee more and more center may be adopting this technique.
Yeah.
Lot of studies in last decades, sir. Lot of studies. That's why that meta-analysis in 2019, 2022, they have compared a lot of this TPS versus needle life versus standard cannulation. All those things they have compared, sir.
The risk of perforation actually virtually negligible with this technique. Even with the
Yes, sir.
the risk of perforation is very low actually.
Should I go
think
to next
Manas,
presentation,
you
sir?
can, yeah, please
Yeah,
go.
thank you. So the last article is again published in GI Endoscopy. Long-term prognosis and risk factor associated with post-ERCP pneumobilia in patient with common bile duct stones. So post-ERCP pneumobilia has been seen in around 48 to 40% of cases post-ERCP. But pneumobilia has been considered as a risk factor for recurrent common bile duct stone, and pneumobilia leads to recurrent common bile duct stone or repeated operation leads to pneumobilia. Again, this is a they are saying that pneumobilia can occur due to repeated operation in recurrent stone, and it has been shown that pneumobilia is a risk factor for recurrent stone. So both the things are playing and coming into action. Varying definition of post-ERCP pneumobilia has been seen. So some studies they have seen within a week. Some studies have been seen there after 3 months they have seen. So varying definitions are there. And enterobiliary reflux and acute cholangitis are there when there is pneumobilia is there. So aim of the study is to comprehensively evaluate the impact of pneumobilia on long-term prognosis of patients who developed pneumobilia between 3 months after initial ERCP and removal of the first recurrent common bile duct stones. So this is a retrospective study done in a single center in China, and they have January 2010 to December 2017 they have taken ERCP patient, and they have included initial ERCP was performed in the study hospital, and then those who have undergone CT and MRI images available in their hospital within a period of 3 months after initial ERCP and removal of first recurrent stone. And they have excluded other bile duct tumor and biliary tumor who have undergone percutaneous transhepatic PTBD or gallbladder drainage or biliary stent placement at the time of evaluation of pneumobilia, colorectal fistula, lymphoma, pancreatic cancer, cystic tumor, adenoma major. So all these are who are lost to follow up. These are excluded. So outcome they have seen single and multiple recurrence of common bile duct stones, acute cholangitis without stone recurrence, acute cholecystitis and risk factor for pneumobilia. They have assessed these outcomes, and this patient flow chart have clearly shown that around 1380 patient underwent ERCP during this study period, and this 1128 has been excluded because they have no, this imaging modality is not there. So CT and MRI images are available at 252. Again, this exclusion criteria they have put this biliary lymphoma, bile duct tumor, all the loss to follow-up and all those things they have excluded. Though patient eventually included in the study is 184, and out of 184, pneumobilia group 53, non-pneumobilia group 131. And out of these, they have done propensity score matching, and they have 1:1 they have taken. So matched after propensity score matching, pneumobilia group 40 and non-pneumobilia group 40 they have analyzed. And if you'll see the baseline characteristic of this both the groups, pneumobilia versus non-pneumobilia. So here we can see that the CBD diameter, periampullary diverticulum, and size of EST. This size of EST, moderate and large EST, these are significant difference between the pneumobilia versus non-pneumobilia group, whether it is pre-matched or post-matched, that is after propensity score matching. And of course, there is difference in number of stone. When there is more than 2 stones are there, there is difference is there. And there is difference in cholangitis and multiple recurrence between the pneumobilia group and non-pneumobilia group out of this. And this table shows there is analysis of risk factor of pneumobilia in full. What are the risk factor of pneumobilia? They have analyzed. They have taken univariate analysis, and they have done again multivariate analysis. And univariate analysis, here it is seen CBD diameter, stone diameter, periampullary diverticulum, size of EST, and number of stone are significant difference between the risk factor of these are the risk factor in univariate analysis for pneumobilia. But when they have applied multivariate analysis, it is the CBD diameter more than 1 centimeter, diverticula, that is periampullary diverticula, and moderate and large EST. That is, they are the risk factor in multivariate analysis for this pneumobilia. And again, they have seen in this table analysis risk factor for pneumobilia with patient of CBD more than 1. And here they have seen large EST and number of stone more than 2 and large EST have significant difference, but moderate and small EST, there is no difference between the moderate and small EST also. And this table shows when CBD diameter is less than 1, is there any difference in risk factor for pneumobilia? There is no difference in risk factor when there is CBD diameter is less than 1. That's why they have proposed normal size CBD or CBD less than 1 centimeter CBD is a protective phenomenon for this enterobiliary reflux, and that is the that's why the reason this pneumobilia, acute cholangitis is not happening when there is normal size CBD is there. So that's why they have discussed pneumobilia subsequent to their initial ERCP exhibit a higher propensity for multiple episode of common bile duct stone, recurrence, and acute cholangitis. And they have multivariate analysis. They have shown that risk factor for pneumobilia are peripapillary diverticula, CBD diameter more than 1 centimeter, and EST with moderate to large incision. So they have defined also what is this moderate to large incision. When they have incision is considered small if it does not exceed transverse fold, and when there is large incision, it is extend reaches up to superior margin of papillary bulge, it is called large. So when there is small EST, there is no significant difference. When there is moderate to large EST, there is difference, significant difference, and it is a risk factor for pneumobilia. So if you'll see, strength is fast study to evaluate the impact of pneumobilia, and there is long-term follow-up. There 8.5 years they have followed up the patient, and they have, though there is imbalance between the two groups, they have done propensity score matching. So both group after propensity score matching, they have again analyzed those group, but limitation again, this is a retrospective study, so chances of bias is there. Baseline characteristic of two group is imbalanced. Lot of difference is there. Lot of follow-up, loss to follow-up is there, and small size for subgroup analysis in this study. These are few limitation, but to take home points are patient who developed pneumobilia after initial ERCP for common bile duct stones have an increased risk for multiple episode of common bile duct stone recurrence and acute cholangitis. However, no cholecystitis. Independent risk factor for pneumobilia are peripublic diverticula, dilated CVD more than 1 centimeter, and EST moderate to large size. So they have proposed normal size CVD appears to a secondary barrier again in this enterobiliary reflux and necessitating further research for this confirmation. So they have suggested that once there is any stone, as soon as we possibly in CBD, we should tackle it. If it is remain for more time, dilatation will be there. Then this barrier function will be lost, and chances of this pneumobilia and acute cholangitis without any stone also chances is more in that. Thank you.
Thank you, Manas. Thank you, Manas. So, in this study, they have done MRCP. So mostly patient had initially CBD stone. They underwent ERCP or CBD stone. And in follow-up, I'm not very sure why they have done MRCP or CT scan. Mostly we follow these patients by ultrasonography. And it's very easy to diagnose pneumobilia on ultrasonography. So they haven't given any data regarding the ultrasound finding.
No, sir.
And second, I think it's more of a association than causation between pneumobilia and the secondary cholangitis.
Yes.
So I think whenever we do ERCP, many times patient have a dilated CBD around 10 to 15 and they have multiple stones. And we know that there is weakening, there weak contraction of bile duct, and the patient are likely to have bile stasis. And in our practice also, we have seen that patient who require multiple ERCPs, mostly they have dilated CBD. And when we do repeat ERCP, they have a soft stone, sludge, and the sludge in the CBD. So it means there is some weakness in the bile duct wall, which is leading to dilated bile duct and decrease in clearance of lithogenic bile. And here I think the stronger risk factor than pneumobilia in causing recurrent stone is more likely to be bile duct diameter. And when the bile duct diameter is larger, they are likely to have larger stone. In this patient, we tend to make larger cut. We tend to use the large balloon dilatation. That's why they are having more pneumobilia in patient who had a non-dilated CBD with a small stone. We always make a small cut to avoid perforation. So in patient with the larger CBD, we are making larger cuts to remove stones that may be leading to pneumobilia. And to me, pneumobilia per se is not leading to CBD stone. It's the CBD actually, which is abnormal in this patient, which is leading to more stone in the bile duct.
Thank you, sir. Pavan, sir.
Yeah, it is that the cut is invariably be required as per the stone size and whatever the biliary drainage has to be taken place according to the stone size. And we have to compulsorily we have to go for larger size incision whenever you wanted to do sphincterotomy sufficiently. The sphincterotomy has to be good enough to do some biliary drainage by balloon or by means of basket. But as Singla said, the pneumobilia is not the cause. That is an effect of our procedure, and whatever we do the sphincterotomy that further goes into those lines of having pneumobilia. And the multiple large CBD stones will which requires definitely a bigger cut, and we may have to do multiple procedures also for better biliary drainage. And here the enterobiliary reflex also, what the article suggests that there is a enterobiliary reflex is also high if you cut the more larger cut. And sphincteroid dysfunction also causes more and more, there is an enterobiliary reflex. And that is one part where it will invariably it happens when after you do the adequate sphincterotomy is a mandatory for doing a good drainage. So here somewhat the cause and effect relationship, when we do the procedure, invariably we land up with pneumobilia. And as Singla said, that the CBD biliary, the smooth muscle dysfunction, which is causing more and more decreased biliary motility, that causes invariably causing the dilated CBD as well as the retained the biliary stasis is going to be more and more stasis will be there. So here it may be a retrospective analysis stating that biliary cut, which is causing more and more pneumobilia, and comparing the pneumobilia and the recurrence of the CBD stones again and again. So somewhat it is interesting article. we maybe have to look into this kind of article with a larger group also. And in our daily practice also, we must see further also in this case. It's very interesting. Chalapati, what do you say?
Yeah, I think there are a lot of confounding factors. Definitely, as said, dilated CBD is one of the confounding factor which can contribute to the stone formation. But my thought is, what are the implications for future prevention if this is right? For example, so are we trying to say that provide preserving the integrity of the papilla, like don't cut it, just do a sphincteroplasty, remove the stone, and let it again reform, so that that will again prevent the duodenobbiliary reflux if that is the cause of it, so that there is no pneumobilia, and definitely that might prevent stone formation. One, two, if the large CBD size is one of the factor, then are we warranted to put a biliary stent in all the cases to allow a better decompression and prevent future stone formation? All these things are still debatable, because pneumobilia itself as a cause of recurrent stone and cholangitis is debatable now. With this study, whether it is actually the cause or just CBD diameter is creating, the confounding factor, and what are its implications. So I'm really intrigued with this study and to see what's going to be the future for this, regarding this study. Yeah.
I think we need a better study design. We should take two groups, dilated CBD, non-dilated CBD. Then do ERCP in both the groups. Then dilated CBD after clearance, pneumobilia or no pneumobilia. Then we should compare chance of recurrent stone formation in patient with dilated CBD or without pneumobilia. Similarly, in the small CBD group, without pneumobilia, with pneumobilia, then we define the recurrence of stone. So that may give us interesting results.
Yeah, but I'm just surprised to see, like, almost all of my ERCPs, after I cut and clear the CBD, there will be a pneumobilia which comes up, right? So I mean, like, what are they talking about pneumobilia? Are you like talking the pneumobilia after 1 year, or after 2
Yes.
years, or after what is it like? I mean, or immediately after the ERCP? I don't know.
Immediately after ERCP, they have not taken because of this cutting effect and because of this putting stent on all those things. So they have taken here after just before 3 months, within 3 months. So they have hypothesized that within 3 months that cutting, recovery of the sphincter body and all those things that we recovered, and there is smooth muscle has been recovered. That's why if there at that point of time pneumobilia is there, they have taken into.
Fine.
So
I think.
thank you.
Yeah. So.
Thank you, our esteemed panelist. Dr. Chalapati, please.
Yeah, please go ahead, Manas.
So thank you to our esteemed panelist, Ravan sir, Vikas sir, and thank you Chalapati, Nitin, and our partner. And next time, that is 35th this month in endoscopy by Dr. Chalapati Rao, that is on 18th June 2024. Thank you, everyone. Thank you to our participant listeners for participating in this month in endoscopy. And we'll invite you all to 35th this month in endoscopy.
Thank you. Thank you all. Thank you.
Thank you, Manas.
Thank you, sir.
Thank you, sir.
Thank you. Bye.
Yeah. Thank you.
Thank you and good night.